a chance to sort of understand the makeup of this audience. So first question for you is, how many of you currently use some kind of mobile device to track anything about your health? You know, whether it be a Fitbit or an app or anything. Get your hands up so we can sort of get a sense. Okay, cool. How many of you... How many of you receive data from some kind of mobile device that's tracking health, but it's not your data, it's someone else's data? It's because you're a clinician, or it's a parent or a child? One, two, okay, about a half a dozen people. Okay, cool. In terms of the makeup of this audience, those of you who are clinicians, some kind of clinical care provider, hands? And this next part you're going to be able to answer more than once. So, again, we're just trying to get a sense as to who's in the audience. I'm sorry, clinical care providers? Okay, about a dozen or so. How many of you are technologists? Okay, you guys are in for trouble. How many of you are business people? Primary focus, sales, marketing, finance? Okay. And how many of you would you consider being on the payer side of the world? Okay, great. Okay, so, oh yeah, one last question. How many of you have been involved in mHealth or any of the other names that we've given this industry for more than a year? More than 3 years? More than 5 years? More than 10 years? Cool. Some of you are as old as me. Okay, so the goal of this session is not to have these guys all tell you what they do for a living. Okay, that's not the objective here. I have to give them that opportunity, because otherwise you'd say, well, why should I bother to listen to you? So what we're going to try and do is to get through a series of very brief presentations which are going to pick up on some of the key issues that they deal with, so that you've got some sense of background, and then we're going to talk. So the presentation portion of this is hopefully under half an hour. Right, guys? And then it's a matter of how well do you interact with them, what kinds of questions do you have them. I've got some questions, and you can listen to me ask them questions if you want. I would rather listen to you ask them questions, because as you could see, sort of the demographic split of this audience, we've got a little bit of everything. So we should be able to approach this with a lot of interesting and innovative ways in terms of trying to get down to the bottom of what is this thing of big data? What is this thing with mHealth? So we're going to really try and focus on having a real exchange on that. Everybody buy that? Everybody buy that? Okay. Thank you. We appreciate that. And that's it from me. So what I'm going to do, I'll introduce each speaker. As I said, they'll give you hopefully under 10 minutes. There is a timer here, guys, by the way. It says 20, so if you hit the button to start, stop when it says 10. So again, the goal here really is to have interaction. We've got a room full of people with lots of diversity in their background and knowledge, so we really should be able to have some good discussion. First speaker today is Chris Christie. He's a senior principal of the healthcare industry and also executive director for accountable care organizations with SAP. Chris brings 16 years of healthcare provider industry experience, including previously serving as associate administrator and COO at several hospitals that were part of American Medical International, now known as Tenet. You served 9 years as VP for professional services at St. Paul Medical Center, 2 years as regional VP for MCare, and emergency room physician group practice. He's a fellow in the American College of Healthcare Executives and has served as an adjunct professor of healthcare strategic planning at Texas Women's University in Dallas. He received his master's in public health from the University of Missouri-Columbia in Columbia, Missouri. Chris, all yours.
Great. Thank you, Tom. Appreciate the opportunity to spend a few minutes with you today. And let's just get this clarified right up front. For those of you who are expecting to see the other Chris Christie, he's not coming. So I know that comes as a lot of surprise to my Twitter followers who can't understand why Chris keeps tweeting about healthcare. Why does the governor keep tweeting about healthcare? But nonetheless, so pleasure to be here. I'm going to spend a few minutes talking about my company, quickly go through their box scores here. SAP is an amazing, incredible company celebrating our 40th year this year. We have about 195,000 customers served by 60,000 employees. We're in 24 different industries, especially healthcare. We are in 120 countries and are serviced by 11,500 talented partners as part of the SAP ecosystem. SAP today has gone through a series of transformations. I've participated in several of those, but we're going to focus on 5 key areas. Of course, applications is what brought us here today. It's how we made our name in the business, if you will. Thousands of companies run our ERP solutions. We are, of course, in the analytics market through our brand names of Business Objects and Crystal. Practically everyone gets a Crystal report. If you file taxes, I'm sorry about that, that's a Crystal report. So nonetheless, Crystal reports pretty ubiquitous. We cover the cloud with 2 of our subsidiaries, SuccessFactors in the HR area and Ariba in the supply chain area, new acquisitions for SAP this year. We also have introduced a new technology in the database area, 100% in memory. It's a technology known as HANA, a high-performance analytic appliance, a combination of hardware and software, 100% in memory. It is fast as lightning, and this product is our fastest-growing product we've ever introduced. And last but not least, of course, is mobility, the reason why we're here. Our mobility solutions, of course, cover apps, a platform, and a stout security client known as Afaria. So let me just begin by asking this question. Is there anybody in this room that doesn't believe that we're in a complete transformation, a world of change? It is an amazing world that we're into. I've never seen change like we have right now. Change in legislation with the new acts that are out, Accountable Care Act, the High Tech Act, that sort of thing. We have changes in care delivery models, accountable care organizations, and patient-centered medical homes, reimbursement models, fee-for-service is being replaced by other mechanisms. It's kind of a funny situation right now. Some have likened the transition to new revenue reimbursement to one foot being on the boat dock and one foot being on the boat, and you know what can happen in that situation. So it's an amazing. There's been an alarming increase in the number of times I've said to myself, back in the old days, the good old days, the golden oldie days, you know, those days before we had fully functioning tablets and that technology, that's only 32 months, by the way, since we've had that. So it's a fact. There are more, and this has been stated more than once today, there are more devices on the planet than people. And that has profound implications for hospitals. It gives them an opportunity to touch their stakeholders in ways that they've never touched before. Stakeholders like physician groups, like patients, like payers, and others in the community. It provides a platform for them to be able to communicate with them, really do population health. You know, this concept, there are billions of items now that connect to the internet and billions more that will connect to the internet in just the near future. The idea of the Internet of Things, where there are embedded sensors and there are devices that throw off data, hospitals can use that. Healthcare organizations can use that to their benefit. Lower cost, provide higher touch to patients, but yet keep costs under control. More data, it's a fact. More data has been created in the last 5 years, and since we come out of the caves and picked up stone tools, it's an amazing the amount of data that's out there right now. Last week, IDC projected that the current digital universe is about 4 zettabytes. And I had to Google what a zettabyte is. It's 1 trillion gigabytes. It's a lot of data. And that's just going to continue to increase. So where does all this data come from? And we're going to talk about this more today. Where does all this data come from? Well, it comes from practically anything that transacts, that handles, that monitors, that measures, anything that has a plug. And that's really not going to change. The idea that biology is now rapidly becoming an information science, information around the genetic code. And frankly, that new data is going to come from us, from our own genetic code. The noted physicist and commentary on the Discovery Channel, Michio Kaku, talks about the idea just in the very near future we'll be able to sequence our own DNA, sequence our own genome, and that's going to present a whole lot of problems to people. For example, 25,000 genes or so, 3 billion or so base pairs. If you have that data in front of you, your owner's manual, if you will, what are you going to do with that? How are you going to feel about that? Do you really want to know what it says? Do you want to know how you're going to respond to drugs? Am I susceptible to Alzheimer's? Do I have the P53 gene mutation associated with roughly half of the common cancers? It's a tough situation. I mean, you really would have to have a lot of intestinal fortitude to decide, do I want to know this information or not? For me personally, I probably do. It's really a decision between you and your physician. So just wrapping up, the road forward. The road forward is littered with people making predictions, and I'm not going to make any predictions this morning, but I will say it will come, the future will come faster and be more dynamic than we could ever possibly imagine. Just look at the pace. Moore's Law applies here as well. So, in conclusion, I'll just quote one of my favorite philosophers, Yogi Berra, who said, you know, predictions are always always hard, especially when they're about the future. Thank you.
Thank you, Chris, very much. Next up, Dr. Joshua Cohen. Dr. Cohen is a professor of medicine at the George Washington University School of Medicine, interim director of the Division of Endocrinology and Metabolism. Received his MD at New York University, trained in internal medicine at the University of Michigan Medical Center. His clinical and research interests include prevention of diabetes and treatment of diabetes, and he'll talk a little bit more about that this morning, metabolic syndrome, thyroid disorders, polycystic ovary syndrome, endocrine disorders in pregnancy, and the other endocrine diseases. Now, personally, as a non-clinician, one of the problems with healthcare is that non-clinicians can't understand any of this stuff. But that aside.
Well, I'm sure everybody's kind of looking up on their apps now.
Dr. Cohen has lectured extensively on these and other topics at regional, national, and international meetings. Current research projects include integration of a cell phone and web-based diabetes management and coaching system with the Allscripts Enterprise Electronic Medical Record System, SMS messaging to reduce ER department visits for people with diabetes, as well as clinical trials in subjects with type 1 and type 2 diabetes. So, please, Dr. Cohen.
Thank you, Tom. I suppose that if there's been a theme to this meeting so far, it's centered around the issues of integration, sharing, and connectivity seem to be the buzzwords that I've been hearing more often than anything else. And so what I wanted to do today was to talk to you a little bit about an integration project that we've been doing at George Washington University. And the goal of the project has been to complete an integration, a system integration between the WellDoc diabetes management product and the Allscripts Enterprise Electronic Health Record to create a mobile integrated therapy platform for comprehensive management of diabetes. The project, by the way, is being supported under a contract from the U.S. Air Force, but they have been completely independent of all the steps involved. Some of you may be familiar with the WellDoc diabetes management product. It includes both a cell phone application as well as a web portal for patients, as well as portals targeted at providers and at care managers. It has the ability to have patients log on data, transmit it to their providers, but also what is somewhat unique about it is that it has embedded within it an artificial intelligence engine that can provide individualized feedback to patients, as well as providing providers with evidence-based guidelines and recommendations for management of specific patients. The product actually has been cleared by the FDA as a prescribable device. Well, but if you think about this kind of a disease-specific application, it really has differences from the electronic health record. Mobile health applications in general are going to be patient-centric and probably more focused on issues of health maintenance and personal empowerment. Very importantly, these applications, in order to be useful for patients, are typically going to be functioning in a real-time basis. And as I suggested earlier, they're typically going to be problem or disease-specific. In contrast, electronic health records tend to be more archival. They provide a historic record for physicians and other providers, as well as a place for documentation. They have to be very general, especially in the typical practice environment of multiple different medical practices, of multiple different medical practitioners. And so when we think about integrating them, there's almost a cultural issue that comes up in terms of taking applications targeted at really two different groups and getting them together. But there are benefits that could come from this integration in terms both for the patients and for the providers in terms of better clinical decision support, access to real-time clinical data on the part of the clinician data that typically they don't see now, ability for advanced analytics, pattern analysis and recognition, the kind of functions that typically are not going to be built into a general-purpose electronic health record. Patients have the opportunity to obtain more frequent reinforcement of their treatment goals, possibly better understanding of what their clinician is intending in terms of their care, as well as access to educational resources and perhaps other messaging systems. When we spoke to providers about what the providers wanted to see out of this kind of an integration, these are the kind of things that providers specified. Access to clinical data which is not currently available, that real-time, day-to-day data. Provide additional value to patients compared to standard care, because there had to be something that was going to be motivating patients to continue to use applications. Aid in meeting current and upcoming regulatory requirements. I'm sure all of you are familiar with the many different regulatory and care and alterations that we are currently in the midst of. Very importantly, seamless access through the electronic health record. Providers did not want to have to be using separate systems in order to obtain this information. And systems that in general would be highly intuitive to use with minimal need for additional practitioner training. And finally, very importantly, an issue that we'll get back to, the system had to be such that it did not generate a significant increased workload for providers. In the Allscripts environment, something that a provider or somebody else using the electronic health record needs to do is called a task. And I can tell you that from now until I leave medicine, I will never be up to date on all of my tasks. As I'm standing here, there are tasks that are coming in for me. And so this issue of workflow environment for providers is an important one to consider. So the way we did this was to assemble a interdisciplinary group that included clinicians, folks from WellDoc, folks from my IT group, some outside consultants who were extremely helpful. And we put together a series of use cases that the systems had to be able to handle. And in the end, we had about 20 use cases, and when I looked through them, I realized they broke themselves down into these 5 groups, which I suspect will be fairly general for other integration-related projects. So patient registration and deactivation, coordination between systems, issues related to data coordination and transfer, which would include clinical information, medications, and laboratory results, messaging functions, report generation by both systems, and finally, issues of system transfer and functional intervention. That is the ability to switch back and forth from one system to another. These are a couple of the issues that we discovered as we were sort of defining and then starting to implement this project. Reconciliation of medications. For any number of reasons, it's important that all aspects of an integrated system have access to a reliable medication database. I'm going to come back to this issue in a moment because you'd be surprised at how difficult it actually is to obtain and then maintain that kind of an accurate medication database. Control of workflow, which I've sort of already alluded to. Very importantly, integration of different care models. Many of the systems that are out there now in terms of disease-specific and patient-specific applications are based implicitly on the model of a patient and a single provider. And yet, as we're now well seeing throughout the entire environment of chronic care medicine, this is more and more being approached by various team approaches. So my diabetes team, in addition to endocrinologists, has other subspecialists that are involved, but very importantly, mid-level practitioners, dietitians, exercise physiologists, podiatrists, and whatever. And so if the two systems have different care models, it's going to be very, very difficult to get maximal advantage from them. Medication reconciliation, I mentioned earlier. I don't know how many of you were at the keynote sessions yesterday, but Shannon Wendling from the Giesinger Clinic reported that when they were doing medication reconciliations, that was in kind of a single integrated system. 16% of the patients were not taking medications on their medication list, and another 21% were taking medications that were not on the list. So that's close to 40% right there, an estimate that I would think low. Add on to that, what you didn't mention, the additional patients who were taking medications but not in the dose or form that necessarily is written in prescribed. And I would bet overall there is well over a 50% chance that the list of medications that your doctors have for you in your medication record is not what you are currently taking. This is just kind of a screenshot. This was supposed to be a movie, but I left the AVI file off. But the point here is that if you could see in the upper right-hand corner, there is a check mark displaying for the provider that this is a patient who is enrolled in WellDoc, and then sort of on the left-hand vertical list where it says diabetes consort, if the provider checked on that, they would be sent into the WellDoc system. Furthermore, you can see some of the diabetes consort messages and reports that have been migrated into the EHR system, so it's directly accessible. Couple of questions that came up in terms of data integration that I think, again, are going to be fairly general. Where did the data originate and what is its validity and reliability? Where is the data stored? EHRs probably are not where the kind of physiologic high-volume data is going to be stored. They're typically not organized to do that. Probably disease-specific applications are better spots to store that. Who sees it? Again, especially in a teen care environment. And very importantly, what is the time frame? And how is that going to be decided, as well as how are patient queries handled? And so I think what we're seeing is, as we go through these integration projects, is the development of patient-centered networks involving sensors and devices, personal health applications, as well as the EHR. And the trick is going to be to get these to function together in a fashion that is fairly seamless, both for the providers and for the patients. So I'd just say in conclusion that integration of healthcare data management systems is frequently desirable. However, integration projects between mobile health management systems and EHR are more than writing technical interface specifications and delivering code. Critical is analyzing the workflow, processing messages, and understanding the types of data, the uses to which they are going to be put. This analysis is best accomplished in a multidisciplinary team environment. Getting the right data in a meaningful way to the appropriate location at the appropriate time is going to be key to the successful integration and to the development of these kinds of highly vertically integrated care systems. Thank you.
Dr. Cohen, thank you very much. Very good. Next up, Nick Corby. Nick leads Marie Stopes International's Innovation and Best Practice team. This team, based in London, and you'll recognize his accent, works to facilitate innovation in MSI, Marie Stopes, and contributes to the identification and sharing of programmatic best practices and innovation in order to strengthen MSI services. Particularly, innovation-related projects for MSI include oversight of the Innovations Fund, training and skills building, and support with the development of key innovations for MSI, including vouchers, SMS data collection, mobile-based clinical training, etc. He's worked with SRH sector for 10 years, first with UNICEF, then with ActionAid before joining Marie Stopes in 2010. Now, this is going to shift us a little bit because one of the questions when I was reading through Nick's bio and understanding a little bit more about his firm is that we talk about data and data deluge in terms of the clinical community, and we talk about it from the technical community in terms of the challenges of putting together all those pieces of data. And I think that one of the things, and I think we can comment on it a little bit later as well, is what about the data deluge in the other direction, the cohort and the patient? So with those words, Nick, thank you.
Morning, everyone. I hope you're all well. I'm slightly alarmed by that. I hope to explode as I run over time. So I'm here to slightly shift direction slightly. I want to talk to you about incorporating SMS within call centres. Chris gave us a good overview at the start about this issue. This will hopefully ground us slightly more and give us some quite live examples. There's two key lessons I want you to take away from this, really, or two insights which our experiences show. One is the importance of interoperable systems and standards, and the other is the benefit of data. Josh touched upon it, and Harry Greenspan touched upon it in this morning's session. Data, it's worthless on its own, frankly. It's how you use it, it's where it gets to and who uses it correctly. And that's come through loud and clear in our experiences. You already know who I am. But let me tell you a little bit about Marie Stopes International. We're a global service delivery organisation focused on family planning. We work in about 38 countries worldwide, predominantly Africa and Asia, and we focus in on the underserved populations. By that I mean the poor, young, those with an unmet family planning need. To give you a sense of the scale of what we do, last year we averted approximately 11,000 maternal deaths and almost 4.5 million unintended pregnancies. To do this, we have multiple service delivery channels, mobile outreach, static centres, social franchising networks. We also use an awful lot of innovation to do what we need to do. Telemedicine, GIS mapping, SMS systems, which is what I wanted to talk about today. Just to give you a sense of SMS at MSI, we use it for multiple purposes. Client information, I'll touch on that again in a second. Health service data collection, for example, in Madagascar, Uganda, Philippines, we collect service data from our social franchisees. They're private providers, basically, that we work with to get our services into the communities where we don't have a static centre. Voucher programs. In Madagascar, we reimburse service providers using mobile money, basically because the banking system isn't strong enough to get us in there. Delivery of vouchers to clients. These are subsidised vouchers that give clients access to services which they wouldn't otherwise be able to afford. In Ethiopia, for example, we're trialling an e-voucher program. Stock orders. In Philippines, we just simply track our stock and make sure that everything that we need is up to date and where it needs to be. Staff communication, as simple as that. Pakistan, Philippines, Uganda. Again, we just use SMS for those needs. So going back to the client services aspect, that's mostly where our SMS use is, and it's mostly in call centres. And again, we use it for various reasons. Getting the information to clients, confirming appointment bookings, appointment reminders, follow-up care and support, administer voucher programs. It's the kind of themes that keep popping through in all of this. And just to ground this slightly more, I just want to dwell on 3 examples of how we do this. In the UK, Australia, and South Africa. Now, we have about 19 call centres worldwide. They vary from one-man operatives with a mobile phone answering questions as they come in to a 24-hour call centre with 50 staff at any one time. It's large, but the variety of services that we provide, there's often quite core ones, and I touched on those in the previous slide. UK is our biggest call centre. It's open 24 hours a day. It has 50 staff at any one time, and those staff vary from call centre agents to nurses, counsellors. The services they provide, it's pretty much everything on that previous slide, information, appointment bookings, and they've used SMS to do pretty much all of that. As of September 2012, they were averaging around about 9,000 SMS per month. I suspect that's only going to go up in the next couple of months as well. There's always a rush towards Christmas for some reason. What those SMS typically deliver are appointment reminders, just to say, don't forget your appointment next week. Also, STI test results. Australia, very similar. The call centre is about half the size, 24 staff members. It's open 24 hours. But during their night time, their calls are routed to the UK call centre. But again, their SMS, similar numbers, similar purposes, appointment bookings, STI tests. South Africa, slightly different. It's not open 24 hours, it's a much smaller call centre, and how they use SMS or how they've integrated it, it's a personal pet favourite of mine. It's an information service, effectively. Clients can ring a standardised number. They're asked to answer a couple of questions just so that we can ascertain exactly what their query is about, and then we can direct tailored information towards their query. Ultimately, if needed, we can just send them the number and strongly encourage them to phone our counsellors for more information or more help. So that gives you a sense of the breadth and depth of how we integrate SMS within our call centres. Obviously, there's a number of benefits and challenges common to all of these examples, and to be honest, common to pretty much every mHealth project that we have. Reduce costs to MSI. Australia, they typically called their clients rather than sent them SMS before that system was introduced to remind them of appointments, to give them their STI test results. By transferring it to SMS, they're making direct cost savings regularly, substantial cost savings. Effective way to deliver health information to clients. South Africa's system, the information service I mentioned, between June 2011 and July 2012, they got around about 41,000 information queries. That's a huge amount, substantially more than they got before their information service was automated. And it's a great way to get that kind of level of information out to clients. Client satisfaction. In every example I've given you and more, we give clients the options to decide how they want us to communicate with them, whether it's through SMS or traditional communication methods. The vast majority are choosing SMS, and they seem to be happier with our services as a result. But there's challenges, and to be frank, behaviour change is one of them. As I mentioned in Australia, before the SMS system was introduced, our call centre would phone our clients to remind them of appointment bookings, especially. The no-show rate of clients before the SMS system was introduced was around about 9% of clients. Since it's been introduced, it's just shot up slightly to 11%. But it just highlights that we've got this great new gadget, but actually it's not changed how our clients approach our services. And finalise standardised platforms. This is the bane of my life, and we're trying to fix it now. But every example I've given you, and others I haven't told you about, there is no standardised platform across MSI. Inherent problems, horrible problems. We can't, without considerable work, look at comparative data, make comparisons globally or nationally. We can't get dashboards for management to make effective decisions, again, without quite a lot of work on our part. The natural cost savings that would have come in by having a standardised platform rather than developing individual data platforms, lost completely. So there's huge problems attached with this. I've been told to keep it short, and this might explode at any moment. So I just want to conclude, but just by reiterating some of those messages that I wanted to take away from you. There is a data deluge. We've got that data deluge in MSI through pretty much every example I've just given you. But the important thing is, and to note, is that data is still important. It's crucial. On its own, data is worthless, but how it's used, and if it's used correctly by the right people, it's invaluable. So just making sure that we give people the skills and the capacity to cut through this data, to make sure that they can make decisions appropriate, crucial. And the other one is interoperable systems. Without that, our job is so difficult, it's silly. Thank you for your time.
Nick, thank you very much. Very insightful. Next up, Mark Tumanosa. Did I get it correctly this time? Yeah. Excellent. Mark is CTO and co-founder of Lumivu, schooled at Berklee College of Music, which I love the fact that I didn't ask when I was doing my demographics how many of you are professional musicians. However, anybody else? All right. But schooled at Berklee, Mark is an accomplished musician, spent 17 years at Bell Labs, where he was a principal investigator in the research division. I'd love to afterwards talk about how you did that. At Bell Labs, Mark worked on everything from the development of the first 32-bit microprocessor to the commercialization of the Unix operating system to the creation and operation of advanced interactive voice services for companies like United Airlines and Charles Schwab. Boston startup Shiva, Mark directed product management and marketing and was a central component in efforts that led to a successful merger with Intel. After the merger, Mark founded OpenReach, an internet security company that provided VPN services. Since OpenReach, Mark has split his time among pro bono work for organizations in human development, in autism treatment, and music. Mark has personally developed embedded algorithms for implantable medical devices, web platforms for autism research, and iOS and Android applications that integrate biometric, environmental, and observational monitoring. A bit of an eclectic background. Mark, please.
How y'all doing? So I'm Mark Tumanosa. I've got some slides which I might use. Well, I guess the first one would be that the predictions are way late in terms of this upcoming data deluge. The data deluge is upon us. Many of us don't see the effect of this deluge on a day-to-day basis, but it's there. One of the things that I've found that people fail to understand quite frequently is cost is not a property of complexity, it's a property of manufacturing volume. If you have the most complex device in the world, but you're putting it into every cell phone and every PDA and every game that goes out the door, it will be cheap. And that's what's happening. You've got gyroscopes, you've got accelerometers, you've got EDA sensors, we've got galvanic skin response just going out so quickly that it's going to be hard to make money as a medical device company for long. I got into this business kind of a funny way. I was 21, I had a kid just then, and I was standing in the hospital with $2,020 in cash and no health care. So I was driving a garbage truck in the day and playing music at night just outside Chicago. And I finally, after about 20 minutes, convinced them I didn't have health care at the hospital and thought, oh my gosh, they're going to keep my kid. And a while later, this administrator guy walks out and he goes, look, he gives me a new bill and it's $2,000. And after that, first I got my kid, which was good. But after that, I decided I needed a day gig that had health care. So I got this mailroom job at Bell Laboratories, and it turns out software is really easy. So it was like, and it's just way better than driving a garbage truck, I gotta say. So I've had this kind of serendipitous career, and I was doing stuff, and there's this guy, Arno Penzias, who ran the research group at Bell Labs, and he saw some of the stuff I was doing, and next thing I know, I got invited to be in the research group at Bell Labs, and I was like the only non-PhD principal investigator, which was, I guess, a lot of people tried to get me out of the position just because of that. But so I just kind of followed things and went where they did. And more recently, my wife became interested in working with kids with autism. And so I became interested in working with kids with autism. And so she'd come home and she'd talk about what happened during her day. And, and she works with families, she goes into homes, and she works one-on-one with kids. And the parents, the divorce rate among parents of kids with autism is 80-something%. It's very stressful. They're constantly retelling every single person that interacts with their child what happened today. I said, well, we can fix that. So I built a little set of web tools that created kind of a secure Facebook for each family, so the family could invite all the caregivers for that child to share, so that everything that happened was documented. And when the kid came home from school, the mom and dad could see what happened in school today, so that they knew before the child broke down that the child was going to break down, and so on and so forth. So that started working. And then one of the little boys that Iris, is my wife, worked with, he's had seizures since the day he was born. He's about 7 now. And so he, in addition to autism, had epileptic seizures every day. And the parents were really stressed out, and the seizures started to increase in number, in frequency. So we thought, oh, well, what we could do is we could outfit his playroom with some cameras and capture what's going on. And then we can do a little anklet with EDA sensors on it and start to use that as a way to know when to look at the video, and let's see what's happening. So we were able to capture several events that we didn't know if they were seizures or not, put them on a little video that we sent to the neurologist just before the next meeting that he had with parents. And this is the neurologist that's been working with this boy for 7 years. And they come in, he goes, you know what? Everything we've been doing is wrong. He goes, and the mom is a writer, right? She's articulate, she can explain things quite well, but still something had been lost in translation. And what he thought had been pervasive seizures in the back were in fact very focused and had a completely different treatment protocol, which they changed a few months ago. And now everything's doing completely differently. And all the data had been there forever, right? It's a matter of figuring out which of it to capture, filtering that down to the meaningful stuff, and getting it to the right person to see it. So that's part of this. The other part of it was, so now this site has integrated biometric sensors, and then not everybody could get to a PC, so now we have an iPhone app that tracks what's going on with that, and all this kind of gets pushed up back and forth, and everybody can share. Meanwhile, since I didn't make that much money in the internet boom, I've had to work too, and so I had a buddy who started a company with an implantable device that's designed to detect heart attacks. So it goes in the shoulder pocket where a pacemaker would go, has a lead that goes in the lower right ventricle. Between that and the can, you get a nice vector, and basically we do an electrocardiogram, 10-second electrocardiogram every 30 seconds. Right, and we're looking for basically ST variants against, anyway, forget that. So what we do is, it's cool. So now you go from something like an iPhone, which is 1,000 times a Cray 1S, and something that has integer math and has to last on a battery for 4 years, and still figure out slope and slope of slope and those variances. So it's a really different kind of programming world. So we start pulling all that data in, and I asked my buddy if I could just start to look at the unblinded data, which was just the strips. And, if you're collecting a 10-second strip every 30 seconds, it's not long before you got a lot of strips. And so I put them all into a database, and it's like a SQL Server database. And I put a little web front end on it so people could start writing queries against it. And then we had also like unblinded demographic information. So, we do things like where people were from, we knew meds and so on. And now you got this database where, normally if you apply statistical methods in a meaningful way, you have to apply them across the population. Now you can apply them across an individual, because you've got tens of thousands of strips of data for just one person. And it just changes completely how you think you might use that data. Because you don't even have to know what you're looking for anymore. You can start to do normalized baselines that move along, and you look for things that are 3 deviations away from that baseline. And they say, that's probably interesting. Let me see what happened there. And so it kind of changes what you do, because now you have enough data where you can really use something that's statistically meaningful without really knowing what you're doing, which is what I'm really good at, that part. I try never to take any jobs I'm qualified for, and I've been quite successful. And I've got 4 bands, just real quick. So, because the one we call Willpower Blues, willpowerblues.com, look it up. We played at the Wynn in Las Vegas this year. Doing a lot of music, and one of the things that struck me, which has been really fun, my company is a little bit smaller than SAP. There are 3 of us, and the other 2 don't write software. So, but what I've found, because we talk about multidiscipline teams, one of the things I've been really encouraging people to do is become self-multidisciplined. Because I think that's one of the things it's going to take to break through this stuff. It's not, you can't see the pattern if you and somebody else are sharing the perspective. But if you have the ability to have both perspectives, you start to see patterns that you wouldn't otherwise see. So that's me. Thank you.
Thank you very much. Okay, so as you can see, we've got a panel here which comes from this data perspective from lots and lots of different angles. I would hope that you've got lots and lots of questions for them. There's 2 microphones here. While the lines start to form behind those microphones for the questions you want to ask them, I do have some. I'll start with a question. So the first question I have for you is, we have all the technology. And as we talked about this, and Mark, one of the examples you gave reminded me of an analogy I give people. How many of you, by a show of hands, have ever had your credit card company contact you to say, is this charge yours?
This morning. Not kidding.
So the algorithms exist. Now, they didn't do that because some person was sitting in a back room looking at every single one of your charges. They were looking for what's the variance, what's the deviant. So we have the technology, we have the appetite to do this, but can we actually standardize on it? What's going to be driving the standardization across all these different areas, whether it be technology platforms? You know, many of you will visit the Continua booth and you'll start to hear about interoperability standards. What about things like standards of care? So please, where are we going to go with this? Where do we start with this?
Well, yeah, I think is this on? I think there are a couple of different aspects. The first is, as I said, the model that I have right now is that there are going to be kind of central repositories, and then there are probably going to be more disease-specific and situational-specific applications as well. And I think the standards are going to be very different because the data collection is going to be very, very different. And to my mind, the system that makes sense is that the applications which are on the front line and are probably going to be receiving data from different sensors and whatever will do their own thing. And where the standards will occur is at the level of the more aggregated data that gets sent between applications, and ideally, perhaps there will be some things that will be kind of in between, like maybe there will be a standard for blood sugars that could be interchanged between all of the different analytic engines that are trying to play with blood sugar records or blood pressure or something or other like that. So it'll give the sort of the small groups the opportunity to be clever and creative in terms of developing applications, but at the same time provide some kind of a platform that would enable data to be shared into more central storage repositories. So that's the model I have.
Well, I was just going to say that the organizations that we work with, oftentimes, it's not the technology. The technology really just enables that, the standards of care and so forth. Many organizations have technologists that teamed up with researchers of all sorts who develop the algorithms. And the algorithms, like the credit card company, that some sort of charge stuck out, and that triggered the call, and it was an automated call to start with. Same kind of thing with healthcare. So an algorithm is going to trigger some sort of event, some sentinel event that will require a clinician's intervention.
And first question, please.
Okay. Yeah, this is for Nick Corby. I just wondered, you mentioned that, excuse me, you're using SMS not only for appointment reminders, but some clinical information such as lab results. And in the U.S., that's pretty taboo at this time because of privacy laws. Do you have you don't have those laws in Australia and UK and South Africa?
Thank you for the question. Yes, we do. We have quite tight privacy laws, and to be honest, MSI as an organisation, we're quite strict on ourselves. Every step of the way, we ask our clients what they want to do, and we make sure that it's in line with the law. You're right, in some developed countries, their privacy laws aren't as strict as they are in the likes of the UK, South Africa, Australia. So we can go slightly further at times, but often we actually use UK standards to try and make sure clients are completely happy.
One of the things that I've been finding working, because I've built websites now that have whole communities of people who are dealing with different kinds of developmental issues with their kids, for example. The privacy laws that we have often mitigate against efficacy. So, for example, parents sharing information. These parents will take their own information. They'll share it on Facebook because sharing that information lets them learn more, lets them communicate more effectively, and causes a better support environment for that child to emerge. So there's a real, I don't think the current models are going to work going forward, right, where someone who's not the person about whom the information is now responsible for the privacy of that information to the point that that person is limited in what they can do with that information. So I think that's one of the things that's got to change. And basically all scientific advancements have been made at times when information flowed freely. And so I think the paradigm's got to shift if we're going to get anything done.
David.
David Aylward from Ashoka. Over the last couple hundred years, we have moved to a kind of a derm medical model back from the historical holistic model. And it's fascinating we're starting to return to the holistic model. But from a very practical point of view, I think we've learned that we cannot solve the health issues without solving wellness issues, that we're not going to be able to solve diabetes in the hospitals. It's going to have to come in people's behavior. And it's going to have to come in nutrition and so on. So in trying to figure out how holistically to make you as well and as vital as we could, or some poor woman in India who's producing underweight babies today, we need a holistic solution. And yet we have a system that's set up to measure individual interventions. And so at a time when nutrition